Greetings. Let me review this topic of antibiotic prophylaxis in patients undergoing GI endoscopy. I prepared this talk for the sake of my first year GI fellows based on ASGE guideline on antibiotic prophylaxis. I would like to talk about two important concepts. One is there a role for antibiotics in patients with cardiac condition undergoing endoscopy to prevent infective endocarditis? That's one. Number two, when you see a patient and you want to schedule that patient for either an ERCP or an EUS or a percutaneous gastrostomy or jejunostomy, what should you do for those patients in terms of antibiotic prophylaxis? These are the major things that you will see in your practice, especially on inpatient service or on endoscopy service. Before we go any further, we should stop and learn about the risk of bacteremia under different circumstances. So let us pause and see. What is the risk of bacteremia if you brush your teeth or floss your teeth? You will be surprised to see this. Pretty high. It is as high as that one would see with variceal sclerotherapy. For the current fellows, you may not see variceal sclerotherapy. This is what we used to do when we trained in the 1970s and 80s before banding became widely available. So you may not see that, but variceal sclerotherapy, pretty high risk in terms of bacteremia. And if you see, brushing and flossing is pretty high in the same range. Similarly, if you chew food, you could also have bacteremia. The risk of bacteremia is high with these daily activities. Compared to that, dilation of the esophageal stricture and simple endoscopy or colonoscopy, the risk of bacteremia is pretty low. For diagnostic endoscopy, it's about 3 or 4%. So what we have learned is transient bacteremia from routine daily activities of life frequently exceed the rates that we see from various endoscopy procedures. And simple diagnostic procedures carry very, very small risk of bacteremia. So when the bacteremia, if you don't have bacteremia, you're not going to get infective endocarditis. That's one thing we should know. So in the last 20, 30 years, we also learned that there was no causal link between the various GI procedures and infective endocarditis. And because of that, the cardiology societies and the GI societies agreed that there is no, and the ID societies agreed that routine administration of antibiotics to prevent infective endocarditis is no longer recommended. So when I was a fellow, I always used to think, hey, what cardiac condition was there? Should I give antibiotic or not? Now I don't have to worry about that. There are some rare exceptions, high-risk cardiac condition, some type of valve, and the patient is undergoing a procedure with a GI tract infection like septic cholangitis. In those cases, you should consider antibiotics not only to correct that infection, especially provide enterococcus coverage, but also that might even help to prevent bacteremia and settling on those valves and implants and prevent infection. Coming to various other implants that the patients have, pacemaker, defibrillator, synthetic aortic vascular grafts, various orthopedic procedures and processes, we don't have to worry. We can proceed with the procedure without antibiotic prophylaxis. But at the same time, I must add here, if I see a patient who wants me to do a colonoscopy, I tell them that, hey, let us wait for some time till after your joint, after you have had a knee replacement or a hip replacement for the wound and everything to heal. So use your common sense as well. Now coming to the most important facet, we see lots of patients with cirrhosis. We are frequently called to see a patient with cirrhosis and presenting with acute GI bleed. That patient is a very high risk for bacteremia and risk of dying if you do not give antibiotics as soon as they come into the ER. So these patients you should prophylax with antibiotics. We typically give IV ceftriaxone immediately on admission to the ER, and that has been shown to reduce mortality. So take time, and when you see a patient in the ER, the patient has been sitting there with acute GI bleed, and patient has not received antibiotics, try and uh, have a discussion with the ER physician or resident, share with them that prompt antibiotics has been shown to reduce mortality. And that's how we improve the quality of care of patients. Next is peritoneal dialysis. Chronic kidney disease, patient undergoing peritoneal dialysis and comes in for colonoscopy. That patient should receive antibiotics, typically ampicillin and gentamicin, and you should also tell the nurse before the patient comes down for the procedure or comes from home to empty the dialysis fluid from the peritoneal cavity so as to avoid the risk of seeding that peritoneal fluid. Very important. Now let us switch gears and talk about when you refer a patient to your therapeutic group for an ERCP, either they have or EUS, what should you do? If the patient is jaundiced and the patient has a stone that you know that your team is likely to remove it and clear the duct and clear the obstruction with complete drainage, or with pancreatic cancer with biliary obstruction, you know that your team is going to be successful in putting a drain or a stent. So in those cases, whenever you intervene and you can drain the duct completely, no need for prophylactic antibiotics. However, if the duct remains obstructed or if the duct remains in a state of incomplete drainage, you should give antibiotics. And what are the scenarios? One scenario that you can think of is a bile duct that got lots of strictures. Think about patients with PSC or patients with liver transplant and presence with multiple strictures, or a high hilar obstruction where you may or may not be able to drain the ducts where you put in the dye. So those situations you should give antibiotics. So in other words, where you can completely drain and clear the duct, no need to give antibiotics. Whenever there is a question of incomplete drainage, give antibiotics. So now we move to patient that is being referred to your therapeutic group for EUS-FNA. Then you think, is it a solid lesion or a cystic lesion, like a pancreatic cancer or a lymph node that your therapeutic group is going to put a needle and obtain some cells? Those solid lesions, no need to give antibiotics. Infection is extremely rare. On the other hand, if they're going to puncture a cyst, whether it's a mediastinal cyst or a pancreatic cyst, prophylactic antibiotics is recommended to cut down the risk of infection in mediastinal cyst, mediastinitis, pancreatic cyst, cyst infection. So now let us talk about what should you do in patients that are going down to the endoscopy unit for a PEG placement or a PEG placement. These patients need antibiotics before they undergo the tube placement. Typically, we give IV cefazolin 1 gram 30 minutes, exactly 30 minutes prior to the procedure. I frequently see this where the patient comes into the endoscopy room, they're sitting there waiting for the procedure, and the patient comes into the room, and then we try to give antibiotics. Versus give the antibiotic while they're waiting in the pre-op, as soon as you know that the patient is going to go for the procedure in the next 30 minutes. That's what surgeons do. Surgeons and anesthesiologists work very closely to make sure that the timing of antibiotic is 30 minutes before the skin incision, so that you have the antibiotic getting into the stream and going through the circulation and being available at the skin incision. Right. So let us summarize all the stuff that we've learned so far. So where do you give antibiotics routinely? Always give antibiotics in patients who undergo gastrostomy, endoscopic gastrostomy, or endoscopic jejunostomy. Always give antibiotic in any cirrhotic who presents with a GI bleed. The sooner you give, the better it is, as it's been shown to reduce mortality. You should also consider antibiotics if during ERCP there is incomplete drainage, during EUS you puncture a cyst, or you plan to do colonoscopy in a patient undergoing peritoneal dialysis, and high-risk heart conditions with underlying active GI infection, especially ERCP with cholangitis. There is no need to give antibiotics in patients undergoing orthopedic joint replacements, patients with implants like pacemakers, defibrillators, for just regular diagnostic scopes in patients with heart condition, and unobstructed ERCP, or otherwise you do an ERCP and you clear the duct or you drain the duct completely, then there is no need to give antibiotics. I hope this is helpful. Thank you.